Hi, hello everyone. My name is Anchaleena Mandal, and I'm a second year family medicine resident at the Queen's Family Medicine Residency Program. And today I'm going to be presenting to you about a primary care approach to intimate partner violence, or IPV. This presentation is actually a product of my resident research project, which I did under the supervision of Dr. Amrita Roy. And it's based on a literature review as well as opinions of experts that I've interviewed in this field. And a modified version of this presentation was presented during grand rounds for the Department of Family Medicine. So at times I'll be referring to the city of Kingston and the province of Ontario, but everything that I'm going to be discussing in this presentation should still be relevant for any family physician practicing from coast to coast in this country. So let's get started. Um, I do want to mention that some of the matter that we'll be discussing today may be sensitive. But, if you need to stop this video and take a break, please feel free to do so. And without further ado, let's get into it. First up, I want to ask you a personal question. Raise your hand. How many of you watching this video today pee with the door open at home with your family members around? Like, anyone pee with the door open at home, like your family's walking around and your door's open? Well, raise your hand if you do. I'm sure some people have their hands up, like if you have little kids following you around. But I'm sure that most of you will agree that sometimes privacy is important from even some of our most supportive people. And sometimes we want that door to be closed. Okay, next question. Raise your hand if you feel safe at home. Like after you finish this video or when you go home today, at the end of the day, do you feel safe going home? Think about it. And I'm going to ask you another hard question. Raise your hand if you feel like you've ever been hurt by someone before. It can be in any type of hurt, like even emotionally, like someone told you your shirt is ugly. Raise your hand if you've ever felt hurt before. What I just did right now is screen you all for IPV. It's as simple as that. And we have a lot to cover today, but I hope that you will take home from this presentation is how prevalent IPV is, how to, universally screen your patients for IPV, and how to best support your patient when you do get a yes. So let's get into it. What is intimate partner violence? There's no universally agreed upon definition, so we'll go based on what the World Health Organization says. They say it's a behavior by a current or former intimate partner causing physical, sexual, or psychological harm. It can be in many forms, including physical aggression, sexual coercion, psychological abuse, or even controlling behaviors. It could even be financial coercion or stalking behaviors. IPV is sometimes also referred to as sexual assault and domestic violence, or SADV. And it's all about power and control on the part of the abuser. And the power and control wheel that we have on the slide here shows 8 different tactics by which abusers achieve dominance over their partners. It was developed in the early 1980s in Minnesota, based on interviews of female IPV experiencers. And nowadays, if you search online, there's a gender-neutral version of this wheel as well that you can find. And the cycle of IPV makes it difficult for individuals to leave their abusive relationships because there's periods where the violence lessens, the abuser makes up with the experiencer, love bombs them, promises it'll never happen ever again. But then the tension recurs, leading to another cycle of violence. I want you to take a few seconds here. Close your eyes. Imagine what an experiencer of IPV looks like. Just think about it. What gender are they? What are they wearing? How educated are they? Take a few seconds, think about it. And I also want you to think about what influenced this image in your mind. Was it social media? Was it a personal experience? Movies? Stereotypes? Think about it. Whatever you thought about, erase that image from your brain. Wipe it clean because anyone can be an experiencer of IPV, regardless of age, gender, sexual orientation, socioeconomic status, educational background, doesn't matter. It can occur in heterosexual relationships, same-sex relationships. It can be in married, common law, or even prior dating relationships that have already broken up. And we've seen high-profile cases in Canada, like Dr. Ilana Frick, who was a University of Toronto family physician. She was murdered by her husband, who is a neurosurgeon. No one is immune to IPV. And IPV is more common than you think. Worldwide, 1 in 4 women have been exposed to IPV at least once in their lifetime. And as you may have noticed, from all of the stats, yes, IPV is predominantly gender-based. Women are disproportionately affected, almost 4 times more likely than men. But please realize that male IPV experiencers do exist and are often stigmatized, so please have some compassion for them as well when they come as your patients. In Canada, as many as 4 in 10 Canadian women have experienced IPV over the course of their lifetime. That's like 6.2 million women. And it's particularly an issue in Kingston, where I'm recording from. In October 2023, the Kingston City Council voted unanimously to declare IPV as an epidemic in the city. And to date, more than 100 municipalities in Ontario have already declared IPV an epidemic. And things only got worse during the COVID-19 pandemic due to factors like isolation, increased substance use, and unemployment. There's also other groups that are at higher risk. Adolescents and young adults are at higher risk of dating violence. Sexual and gender minorities who may be prone to unique forms of violence, like hiding tools or meds that partners use to express their preferred identity, or using wrong pronouns intentionally, or threatening to out their partner. Of course, immigrants, racialized and ethnic minority groups, like Indigenous individuals, are twice as more likely than their non-Indigenous counterparts to report IPV. Persons with disabilities who may be reliant on their abuser. Rural rates of IPV are almost 75% higher. Older individuals, and poverty for individuals who might be financially dependent on their abuser. It is a significant public health issue. Individuals who experience IPV may present to acute or primary care with physical injuries, fractures, TBIs, STIs, unintended pregnancies, and chronic pain symptoms. Women who have experienced IPV were almost twice as likely to experience depression and alcohol use disorder, among other things like, PTSD, anxiety, suicide, and self-harm. And the Department of Justice of Canada estimates each year about $7.4 billion are spent on the aftermath of IPV. That's like double of what's spent on congestive heart failure patients. And of course, the worst case scenario. 1/5 of all solved homicide cases in Canada were committed by an intimate partner. That is, in Canada, a woman is murdered every 2.5 days. And of the women who were murdered by an intimate partner, 45% of them have presented to a healthcare professional for treatment of IPV-related injuries in the 2 years before their death. That's where you come in. Nearly 1 in 4 women presenting to your clinic have experienced IPV in their lifetime. And as family physicians who have longitudinal, trusting relationships with our patients, you can play a pivotal role in halting that cycle of IPV through screening, offering ongoing support, and documentation. And that can increase safety for your patient and improve health outcomes for your patient. And you can literally save lives. And if I haven't convinced you yet, identifying and caring for women experiencing SADV is a core competency for Canadian graduating family physicians. So if you're a resident, Listen closely because this might be on your exam. Let's talk a little bit about screening for IPV. We cannot identify IPV if we do not ask patients. So what do the guidelines say? Well, in 2012, the United States Preventative Services Task Force guidelines advise clinicians to screen all women of childbearing age for IPV and provide services for those who screen positive. But the Canadian Task Force for Preventative Healthcare says there's currently insufficient evidence to recommend screening of the general Canadian population. But this idea of insufficient evidence is based on limited literature about the impact of the management after screening, because most of these studies are done in the ER with limited follow-up, and also resources vary so much from place to place. So the waters are kind of muddy here. What happens in practice? Well, many physicians do case finding. They inquire about IPV if they see suspicious injuries or clingy boyfriends. But the issue here is that they actually have a low positive predictive value for identifying patients who are being abused. So what experts have concluded is that in primary care, every patient of any age should be routinely screened for IPV. And routine screening normalizes this interaction. It's non-judgmental, and there's evidence to show that it doesn't cause any harm. I would say, like, don't screen at every visit because that's kind of awkward. But make it natural. Build it into your contraception visits, pap tests, diabetes visits, prenatal visits, for example, and follow up for repeat presentations of the same presentation. Make it natural. And for residents, as an FYI, the CCFP exam follows the Canadian Task Force guidelines. So for the exam, screen only if you think things look suspicious, but in real life, screen routinely. Sadly, screening rates are pretty low in primary care settings, as low as 5 to 10%. That's very disappointing. Like, come on! The majority of patients want to be screened. 93% of women believe that physicians can be helpful and are willing to disclose. So what's holding us back? Well, some doctors are saying it's just too hard. Like, it's hard to ensure privacy. I just don't have enough time. I'm anxious because I don't know much about this topic, or I've never been trained on this before. And that might particularly be true for some of the residents. But after this presentation, you will all be pros at this. No excuses allowed, okay? So let's see how much you know already. Let's give this a shot. So imagine your patient Jaden is here for abdominal pain for the third time. Third time. Could this be IPV driven? I mean, it could be, couldn't it? I want you to pause the video here for a minute and try practicing how you would screen your patient for IPV. Give it a shot. Pause the video right here. How did it go? How did it feel? Don't worry if you weren't sure about what was going on or what to do, because we will go through this step by step. It'll make more sense soon. Okay, first of all, how do we set the scene? Well, one easy thing that you can do is displaying resources, pamphlets, hotline numbers, and posters in the waiting room and in the washrooms to reinforce the message that the clinic is a safe place to talk about IPV. Second, use professional interpreters as needed to allow patients disclose away from their abuser, who might be their ad hoc translator. Third, use a trauma-informed approach to creating a comfortable environment. Introduce your role, your name, and your pronouns, and ask the patient what their preferred name and pronouns are. Make eye contact, listen actively, and don't make it seem like you're rushing to see the next patient, because that's going to discourage disclosure. Help restore the patient's power and control over their lives. Ask for their permission for exam, ensure proper draping and privacy, and follow their pace. Avoid re-traumatization. Instead of calling it a bed, call it an exam table. Don't tell patients to open up their legs for me. No, 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 no. Consider saying, can you please drop your knees to the side? Or during a speculum exam, rather than saying, you'll feel my fingers, no. Instead, you can say, you will feel my gloves. Finally, I want you to also recognize your biases. You come from your own family background, your own perspectives in life, and some of you might even have your own personal history of trauma. So be aware of this and how you might judge a patient's decisions, especially if that decision differs from your own. So now that you've set the scene, how do you ask the question? Well, there's various ways of bringing up IPV, and it's important to use whatever phrase works best for you and your patient care style, because it's only an awkward question if you approach it in that way. So step one, make sure to ask about IPV in a private setting. You could ask the patient to wait, the partner to wait in the waiting room for a few minutes, or ask them to step out during a physical exam. And remember that joke I made about peeing with the door open? You can make that joke too if you needed to ask for the partner to leave the room. As best practice, they suggest framing statements to be used at the beginning of assessments to reinforce that screening is a part of routine practice. And it's not because we're suspecting IPV here. Some of you might find this a little awkward and artificial, so you do what works for you. You could say something like, we've started asking all of our patients about healthy and safe relationships because it can have such a large impact on your health. Next, remember to discuss the limits of confidentiality upfront and clarify your role. Remember that warning sign slide I had on the second slide about sensitive matter to be discussed in this presentation? Same concept here. Give your patients a heads up. You could say, before we get started, I want you to know that everything you say here is confidential within your care team, except for certain cases, like if there's children involved who might be exposed to violence in the home. My priority is your safety, and I'm here to support you. Is it okay if I continue? And if they say yes, you can start screening with a simple question, like, how are things at home? Is home a safe place for you? It's a simple, non-threatening, non-judgmental question. And we ask this all the time in the heads assessments, and I even asked you at the beginning of this presentation. So why can't we ask everyone, right? To how I asked you at the beginning if you've ever felt hurt by someone before. Similarly, based on your patient's response to the safety at home question, you can ask follow-up questions, because safety is a vague word. People might be abused at home, but they still feel safe at home. So you can follow up with, are you currently in a relationship? How would you describe that relationship? Do you ever feel scared in your relationship? And if you're suspicious about a specific type of violence occurring, give examples that are practical and that people can relate to. Like, has your partner ever put you down, called you names, choked you, thrown objects at you? You get the point. For sexual abuse, some experiencers think it's okay for their partner to get sex by force because they're in a relationship or they're married. They don't consider it as rape. So you can say, do you ever have sex with your partner when you don't really want to? And that can help you identify sexual assault. There's also many helpful screening tools, although not validated in primary care settings, that you can use in person or incorporate them into your intake forms. My favorite is the HITS tool. It describes the abuse in simple words, but it doesn't cover sexual abuse though. So in that case, the HEART tool might be a better option for you. And there's other ones that I've listed on the slide here. Some of them are too vague or too long, but you can check them out as well and see if they work for you. Let's talk a little bit about responding to disclosures. There's three types of responses that you might get from patients, okay? You might get a no, And that's okay to get a no the first time. Even if your concern remains, it's important that you don't pressure a patient into disclosing. There's no point in saying, "Ooh, but I see those finger bruises on your arm. What's that about?" That's not going to be very helpful. It's going to make them more defensive, and they're never going to come back again. So instead, it's helpful to say, "That's good. But if that ever changes, you can talk to me anytime. I'm here to help." Now, you're going to have a second group of people come in, and they would say, "Yes, I've experienced IPV before, but everything's okay now." In this case, you might say, "Thank you for telling me. I'm sorry to hear this. How are you now? Is there anything I can do to help?" Because, prior cases of abuse can still have impacts on a person's health. And then you have the third group of people who say, "Yes." And if you get a yes, do not panic. Do not show signs of shock, because if you show signs of shock, the patient's going to get really embarrassed and shut down. Instead, take a deep breath. Remember, for IPV, it's not your responsibility to fix everything. It's already happened. But what you can fix is how a person heals subsequently from it. Your job is to listen, to believe, and to support. So, your patient said yes. What do you do now? Well, first, express gratitude for their bravery for telling you such a private and sensitive thing, because many people are embarrassed that they've let this happen to themselves for so long. So you can say, "I want to thank you for telling me this, because this is really personal information that's hard to share." Next, validate the patient that violence is not acceptable and it's not their fault. You can say, "No one deserves to be abused. Everyone deserves to feel safe at home. The abuse is not your fault." And some people might not see it as abuse, and some of this might be culturally based. So you might say, "Are you aware that somebody putting their hands on you without your permission is wrong?" And this question might get them to start thinking about it and reframe their perspective. Third, let the patient speak and tell their story. Listen actively. Stop looking at your computer and taking notes. Ask open-ended questions and show compassion. And finally, ask how you can help. There's no right or wrong approach. Some patients just want you to listen. Others want medical help, and others just want to know about resources. Let the patient guide their care. It's really important that you screen your patient's risk of death through a safety assessment. This is for all patients. Ask about previous types of violence and the presence of weapons that can be used. Clearly, guns are a red flag. And you can use the Danger 5 assessment tool that I have on the screen here. It's just 5 questions to assess the patient's risk and act based on the scoring system. But I want to mention something here. Do not pressure the experiencer to leave their abuser if they're not ready. What we need to realize is that people have the right to make bad choices, because you don't know what may happen if they don't go back. Experiencers might not be able to leave because of financial dependence, immigration status, challenge finding housing, or child custody, among many reasons. And they also faced the highest fatality risk upon leaving their abuser. So if your patient wants to stay in the relationship, you can say, "I understand what you want to do, but I'm worried about your safety, and I want to make sure that if you're going back home, that we make it as safe as possible." And that's what the quote that I would really emphasize for them. Okay, for all experiencers, regardless of whether they stay in the relationship or not, it's important for us to do safety planning. And this involves counseling the patient on how to reduce their risk of getting harmed and how to escape if violence escalates. So during your appointment, advise the patient to avoid dangerous areas in the home, like the kitchen or stairs during violence, and know all of their exits. Reiterate to your patient the importance of calling 911, going to a shelter, and having a safe contact on speed dial. Advise them to have an emergency bag ready with important documents, medications, money, and keep it somewhere safe that's easy to access. And if they're going to be leaving their abuser, encourage them to deactivate GPS on their phone and in the car on their way out. There's a few more things that you can add. You can find all of these on safety plan templates, for example, offered by the Victim Services of Kingston and Frontenac. If you're in another province, there's lots of different safety plans out there. Just Google, and there's one from each province that you can find. And they often have more points that you can counsel your patient on. Okay, medical management. CPSO in Ontario says medical management always comes before any forensics considerations. So perform a physical exam as guided by your history and use trauma-informed approach. Do not worry about doing a pelvic exam out of fear of ruining evidence. Just do medical exams and necessary treatment first. That always comes first. You can provide analgesia, tetanus shots, imaging, and any treatment that may be necessary. And if the patient was sexually assaulted, you can offer STI testing, HIV PEP, and Plan B or a copper IUD if they wish. And you can also consider screening their mental health and offering counseling and medications as appropriate. And also, I would encourage you to assess for safe substance use and offer cessation support as needed. There's two more things that I would encourage. Concussions often get missed in this population, and as a family doctor, you can screen for TBIs by asking, has anyone ever hit you in the head? Or have you ever hit your head on a wall? Or have you ever fallen back and hit your head? Ask about headaches, memory loss, blacking out, tinnitus, dizziness, seizures, hearing problems, difficulty concentrating, seeing stars or spots, confusion, or volatile behaviors, which are unfortunately often mistaken as intoxicated behaviors. Do a neurological exam and head and neck exam. You can do all of these in the clinic, and if you're worried based on your history and physical, a CT scan is gold standard to assess for injuries, so send them to the ER. And for a family doctor, management largely involves helping patients cope with their disabilities and getting accommodations at school or at work. And unfortunately, some patients might need admission and rehab. So again, if you have any concerns, send them to the ER. You know, some of the patients who tend to miss appointments or show up late all the time, they actually might have concussions and head injuries and are having difficulty attending these appointments for that reason. So keep that in mind and have compassion for them. Another thing I would encourage you to keep an eye out for is strangulation. Strangulation is defined as pressure around the neck with enough force to block respiration and blood flow. A juice can, beer can, pop can, everyone has opened a can before. So if you can open a can, that's all the pressure you need to create damage. And it only takes 5 to 10 seconds of that pressure to make someone pass out. Experiencers might describe it as being choked, or you can screen patients by asking, has anyone ever put pressure around your neck? And on history, I would encourage you to ask about a sore throat, difficulty swallowing, or voice changes. Look for neck swelling, contusions, or ligature marks. You can assess for loss of consciousness, facial or postauricular, intraoral, or conjunctival petechial hemorrhage, and loss of bowel or bladder control during the episode. And strangulation can cause carotid artery dissection, stroke, or pulmonary edema, so screen for these as well. If you're worried about damage, the gold standard is a CT angiogram of the head and neck, so consider sending them to the ER. But if you don't find any concerning features on history or physical, there's a strangulation discharge instructions handout that's available in multiple languages on the Ontario network of SADV treatment centers website. So go to the resources section and select strangulation from the drop-down menu. Reporting. In Canada, there is no mandatory reporting by a healthcare professional to police for sexual assault or intimate partner violence, even if you're concerned about the patient's safety. The decision to involve legal authorities for IPV at any stage belongs entirely to the abused patient alone because they know their situation best. However, there is mandatory reporting in the following situations: to Child Protective Services for any child 16 years old or under experiencing or witnessing SADV, to police if there's an elder at risk in a long-term care setting or retirement home, to police if there's a gunshot wound, and if the assailant is a registered healthcare provider, to their registered college. And you do not need permission of the patient because this is your legal obligation. But it's nice to inform your patient of your responsibilities before starting the conversation. You know, kids see and hear everything. Exposure of a child to IPV in the home, even if a child themselves are not being abused, is an adverse childhood experience. The ACEs that we all have probably heard of about at some point in our training. And the ACEs have long-term health impacts, including on mental health, substance use, school performance, behavioral problems, and chronic health issues. Research shows that children who witness violence are more likely to grow up and become an assailant or face abuse because it becomes normalized to them as an acceptable response to stress. And that's why it's important that patients be advised of your reporting obligations before any inquiry about IPV exposure, because often patients are worried about having their children taken away. But you can reassure them that the role of Child Protective Services is to support the non-offending caregiver in keeping children safe and free from harm. It is a collaborative effort, and you can offer patients to call Child Protective Services themselves, or you can do it together in your clinic and provide that as a safe space. Sometimes, though, you might feel unsure, like, does this need to be reported? If that's the case, you can always do a hypothetical or backdoor consult where you call them and you describe the situation and ask if this needs reporting. Okay, now is the moment that you've probably all been waiting for. Where do we refer our patients? This is kind of difficult because I need to cover both resources in Kingston and outside of Kingston and across the country. So I'm going to make it simple. I'm going to go through 3 main resources and 8 different categories of services that you need to remember. Trust me, it's going to make sense. So these are the key resources that you need to remember. For people from Kingston who are watching this video, you can download the IPV Survivors Handbook that was just released in October 2024 by the Kingston Frontenac Anti-Violence Coordinating Committees. It's found on their website, and it literally has a list of all of the resources that you need to know in Kingston, based on similar categories that I've laid out. If you're elsewhere in Ontario, I would encourage you to call or text 211 or check out their website, particularly the abuse and assault section, for more resources in your location. And if you're outside of Ontario, the Government of Canada has a great page with links and phone numbers to common resources in each of the provinces. And if you're in a rural area, it's a bit hard, but I would encourage you to reach out to your tertiary care center that's nearest to you and ask about their local resources and for support. The benefit is that virtual care is now possible, so it allows for things to be much more accessible in rural areas. Okay, going back to the 8 categories that you need to know. The first one, for patients who disclose depression or anxiety, the number one thing we do is give them a crisis line number. So why can't we do the same for IPV? There's lots of local hotlines, but the 3 big ones that I'm going to talk about today is Kingston Sexual Assault Center, locally in Kingston, the Assaulted Women's Helpline of Ontario, and the Canadian Human Trafficking Hotline nationally. 24/7 hotlines, you can call them whenever. Also, in family health teams, we are blessed to have social workers who can not only connect patients with local resources, but also provide patient education on grounding techniques, mental health check-ins, housing or ODSP applications. So if you are working in a family health team and have a social worker, use that resource because it can make quite a big difference for your patient. In most communities in Ontario, we're fortunate to have a SADV program physically located at a hospital. They can provide medical care, counseling, safety planning, community referrals, and forensics collection. So, if your patient does not wish to pursue a legal investigation or a forensics workup, you as a family doctor can lead the medical care and refer to the SADV team if needed for additional support. If your patient, however, does wish to pursue an investigation and have forensics collection evidence collected, best practice is to refer the entire medical care to a trained SADV nurse who is familiar with all of the steps of forensics evidence collection, including photography, so that it's admissible in court. However, again, don't let this stop you from providing urgent medical care. Don't worry about your exam messing up any evidence because just because an SADV nurse does an exam and tries to collect a sample right after an assault doesn't necessarily guarantee that they're going to be successful at collecting any DNA. So medical care always comes first. If you find yourself unsure of what to do, you can always call the 24/7 navigation line that can help you find a program close to you and receive guidance on any care that you need to provide. For mental health, I would encourage you to reach out to your local resources. In Kingston, that's the AMHS, Resolve Counseling, and the Center for Abuse and Trauma Therapy that can provide IPV-specific supports. And aside from shelters being a life-saving resource, they often have counseling and social work services there as well, so making it an amazing resource. Kingston's women's shelter is called Interval House. It's not easy to find online, the address, but any cab in Kingston can take your patient there. And unfortunately, we don't have a men's shelter here, but there's multi-gendered homeless as well as emergency shelters, or the integrated care hub that your patient can go to. And if you're from outside of Kingston, you can use the safe shelter or the domestic shelters databases to find your local shelter. A few more resources. Luke's Place and the Clio website are great resources to help IPV experiencers understand their legal rights and the family law process. And to put this into action, you can direct your patients to local law clinics who can provide often free legal aid sessions. In Kingston, I've listed the Queen's Law Clinic, the Kingston Community Legal Clinic, as well as the Legal Aid Ontario Clinic. And also there's the Family Court Support Worker program with Resolve Counseling in Kingston that can help patients to navigate the legal process and forms and what forms need to be filled out for that. Police. While patients are often afraid of involving police, they can actually be helpful in many ways, including wellness checks, releasing a no contact order, and placing charges to help separate individuals from their abuser. And with the patient's permission, you can contact the local police and ask for the Criminal Investigations Division, in particular, the Intimate Partner or Sexual Assault Unit. However, it's important to note that not all locations have an SADV unit, so patients might actually get a road officer who isn't always familiar with managing IPV. And if that's the case, patients can look forward to the victim services support worker. Who are they? Well, they are a fantastic resource. The victim services support worker can be contacted at any point for a support worker to come in and speak in person to the patient to help your patient with emotional counseling, safety planning, emergency financial support, escort services, as well as navigating social and legal services. Both at Queen's University and St. Lawrence College here in Kingston have student groups that can help with safety planning, applying for academic accommodations, filing complaints, referring to community resources, as well as awareness campaigns, among more things that they can do. And there's often similar programs in universities that may be in your local community. On a separate note, I do want to mention that for perpetrators, there is the Partner Assault Response Program by Resolve Counseling that offers a 12-week structured program to help perpetrators examine their beliefs and behaviors and hopefully break that cycle of violence. And this program is often court-ordered, but self-identified perpetrators can actually attend, although unfortunately, it's very rare. So, what if a patient comes to you and says that their partner has threatened to kill them tonight or was going to hurt them and they ran to your clinic for help? This is a situation we fear the most. There's no guidelines on what to do in this case, so here's what experts have suggested. First, complete a safety assessment. If you feel like there's a high risk for the patient, encourage them to call the police and get them involved and explain to them there's just some things that you can't do as a healthcare professional, like a court order for no contact. And you can offer the patient a safe place in the clinic to call the police, or you could even do it together in the clinic. And also remember to call Child Protective Services together if applicable. Now, if they decline involving the police, safety planning kicks in. The worst possible thing that can happen is for them to go home and get killed. And so suggest to them that instead they go to a shelter or to a friend's house where they can be safe. And you can even call a cab for them if needed. Now, what if they decline going to a shelter? Perhaps because of a previous bad experience, or what if they just don't have any friends? Well, you can suggest to them that they speak with the local SADV team. Now, if you're really concerned about their safety, there's always an option of sending them to the emergency department, although the emerge doc isn't going to like you very much. But, it has the capacity for security and can hold patients overnight until resources can be put in place. And at any point, you can call victim services to come into the office to sit with the patient and chat about options and services, and sometimes even provide escort accompaniment. And yes, you can call the police if there's imminent risk to your clinic at any point, like to your staff or to your patients. Like, for example, the partner comes in showing up to your clinic with a gun, for example, or actively threatening your clinic staff or patients, or wielding a weapon, for example. In this case, explain to the patient that you are worried about your clinic staff and patients, and the police plays the role of security in this case. So yes, you can call the police in that case. Documentation. Documentation of the clinical interaction provides important evidence for any future legal proceedings. And complete documentation should include timeline of events, any reported weapons used, medical history, physical exam findings, the results of imaging and labs, as well as any referrals and reporting. It's important to remember to remain objective in your documentation with words like patient states or patient reports. Don't use words like patient claims or alleges because they imply skepticism and are often legal terminology. And the Crown really does not want you to include these kind of terminology. And also don't include quotations because it's not medically relevant and it's often hearsay. I also encourage you to document visible injuries by describing the location, size, and color, but avoid commenting on suspected age of injuries like bruises, because that's often been controversial in court and are often found to be inaccurate. I would also encourage you, do not take pictures of injuries by yourself. Ask the SADV team to take photographs because they are trained in taking forensics photography in a specific way so that it's admissible in court. Also, if you're in a paper charting hospital or clinic, write legibly. It would be really embarrassing to be subpoenaed to court to explain your charting. And finally, be mindful of what you're writing because patients can get coerced into getting their medical records released. So, if anything, do not document details of the safety plan because if the assailants get their hands on the records, they now know all of the secret places and plans that you had to put in place. So that puts the patient at risk. And finally, follow-up is key. So maybe book a longer appointment the next time. You can tell the patient, I'd like to have more time to discuss this with you. Would you be interested in booking another appointment so that we can chat more? And if you're worried about their safety, forget about your schedule. Focus on the patient in front of you. You can ask a colleague to see your next patient for you, or ask the front staff to give your next patient a heads up about wait times. And finally, at the end of the appointment, pat yourself on the back. You did well. A few final points to go through. While we focus on the patient's experiences, as healthcare professionals, we are also vulnerable to vicarious trauma from our patients' experiences. If you feel like this is the case for you, reach out to a colleague or seek care because there's wellness programs out there specific for physicians and residents, such as with the OMA or Paro. And if you're interested in learning more, there's tons of free resources that you can check out in the handout that I've linked in the description below in this video. And to tie everything together, the mnemonic ALIVES can be an easy way to summarize everything that we've discussed today. Number one, ask all patients about IPV. Screen, screen, screen. Listen to them actively and empathetically. Inquire about needs and concerns. Let the patient guide next steps. Validate that the abuse is not acceptable and not their fault. Enhance safety through risk assessments and safety planning. And finally, support the patient medically and through referrals. Report and document as needed. And that brings us to the end. Home should not continue to be the most dangerous place for patients, and family physicians can play a crucial role in halting the cycle of abuse. So I hope you found this presentation useful and practice changing. And if you have any feedback, you can always email me in the email that I've mentioned in the description below. Thank you for your time and happy screening.